Welcome, and thank you very much for the opportunity to speak again this year. We had a conference last year, you might remember, where we were looking at the future of northern communities in Sweden, Australia, Canada. We had people from Austria as well, I think. So it's great to have these things every year. Today I'm supposed to talk about some aspects of GMC's international relationships and partnerships. We have links all over the world. I've put on the map just some of the ones that I'm more familiar with. We hear from other people today about some of the other projects as well. I thought I could just list everything that we do, but that might not be very interesting. So I thought instead that what I'd talk about is not so much the projects that we do, but the process of working internationally and why we would want to. GMC is the only research company in Sweden that's dedicated to rural health and medicine research. There's a lot of other research going on, of course, but it's done on a project-by-project basis, and it's not really coordinated in an overarching sense. Because of this, GMC fills a very important gap in what's going on in Sweden. And we have a sense of responsibility then to be leaders in this field. I've put up here some of the research areas that we're really focusing on, and you'll hear lots about this today. So workforce development, that includes things like education and training, recruitment and retention, and governance of the workforce. A lot of work on distance bridging technologies, the design of rural health services, and particularly primary care services we're talking about, Sami health and well-being. This next one is interesting. We've started to do quite a lot of work about what I call the geography of rural health, and that is trying to understand our communities and our people, where people live, how they interact with healthcare providers and so on. So this is quite new for us. It means we need to learn more about demography, economy, other aspects of society, and the healthcare needs of rural Sweden, of course. Our focus is a particular kind of rural, and that's the sort of rural that you find here in the north and in the inland. But we also have to work in other rural contexts as well, and that's part of why we have international collaboration. If you look at the main international journal for rural health research, it's called the Journal of Rural Health. I've looked at all the articles published in that journal since it started in 2001. There's only 3 articles which mention Sweden at all. You compare this, there's 200 from Australia, 600 from Australia, 400 from Canada, there's 4 from Ghana. So it gives some indication of how little has been done in Sweden and how little engaged Sweden is in the international research community in this field. So part of our ambition here is to change this, of course, and to become leaders. I said I'm not going to talk about all of the research we're doing. Partly that's because I don't know everything that we're doing. And partly because we have some of our collaborators and potential collaborators here from Germany and from Austria, Australia, Croatia and Norway today, who will talk a little bit about their parts of the world as well. But instead I wanted to look at why we might want to work internationally. Of course, the most critical thing is if we work in international collaborations, we get access to some very intelligent people. It's not to say that there aren't intelligent people in Sweden, of course, but we'll try and work with those as well. Working internationally is very important financially at the moment. So there's Arctic grants and there's Nordic grants and there's European Union grants. And most of these now require you to have international collaborations. So even if you want to get something going, you need to be internationally engaged. The third point, I think it could be argued that in some cases at least doing rural work is not very well regarded in the Swedish context. really since the 1960s, there's been less and less work done in Sweden that's focusing on the rural areas. I've just got an example here. Up until 1969, Statistics Sweden every year did some calculation of the different life expectancies between people living in urban areas and living in rural areas. It was actually a very interesting study. So from the late 19th century, people living in rural areas had like 5 years extra life expectancy than people living in urban areas. By 1969, this gap had narrowed to less than a year. But since 1969, we don't know what's happened. What they do now is release life expectancies for the county, which is not really useful, not nearly as useful for us doing rural work. There's good reasons why rural research hasn't been focused on in Sweden. One is the Swedish ideology, I guess, that people should not be separated on the basis of external sort of variables. So terms like rural, like identifying people as rural, as Sami, migrants, or those sorts of characteristics is not something that's looked favourably at mostly in Sweden. Nevertheless, there's a lot of research that shows that place makes a difference. So I think that we should be rethinking that ideology, at least when it comes to rural. Beyond ideology, there's also, I think, been a lack of leadership in Swedish rural research, probably again since the 1960s or 1970s. And when I was going through that journal, looking for Swedish contributions, there were contributions from Swedish researchers, but they were about Asia and they were about Africa. So there's some priority given to international research that's not given to doing research in our own backyard. So again, we're seeing here the reasons why GMC might want to take some leadership role in representing Sweden in an international context. The final point is the one that I want to focus on for the rest of the presentation, and that is that working internationally gives us new perspective on long-term problems. And I really want to emphasize the point that these are just new perspectives. They're not better. We're not here to copy what other people are doing or to assume that they're better than us, but they're new perspective. They're new ways of looking at the world. Before I do the case study, I will give a little bit of a list of some of the projects that at least that I'm involved in or that I'm familiar with. And I'll start with, by way of introduction, for our keynote speakers today. So Ellen Kuhlman has come to us from Karolinska Institute, but is leaving us to go to Goethe Institute. Is that right? So in between 2 days in the north of Sweden is where she is. And together we've been looking at issues around workforce governance, and particularly trying to get a European or Swedish perspective on rural health workforce and how it is evolving. It's early days yet, but we're trying to get an understanding of how different rural Sweden is to urban Sweden in terms of how you deal with recruitment, retention, education and training, those sorts of issues. Anna Vuin is a multi-international, born and raised in Croatia, educated in Austria and now in Australia as a PhD student, although having spent 6 weeks in Storuman and Wilhelmina is seriously considering not leaving, which is good. Anna will be talking about why people move to the supposedly less attractive rural areas. This is really important if you're trying to recruit doctors, teachers, nurses, dietitians, whatever you might need in these rural areas. There's lots of research about how easy it is to get people to move to lovely tropical beaches, mountain ski resorts, places where there's wineries, but not very much about how to get people to move to less iconic places, shall we say. Walter Schoenfelder is visiting us from Tromsø, although originally from Germany, so again, multi-international. It's good when you can cover 4 or 5 countries with 2 or 3 people, makes it cheaper. Walter is interested in how different professions contribute to health and well-being in our rural communities. So he'll be looking at the mix of professions that you might have in a region and how people work together. For example, if you can't recruit a doctor, how does that change what nurses or home care assistants or so on, how does that change what they do, and so forth. Again, we're just starting to collaborate with Walter, but there's lots of opportunities, obviously, across the Nordic North. Just a month ago, we had a conference in Vilhelmina where we were looking at the future for small villages. And here I don't mean the large cities, what I call the large cities like Vilhelmina and Storuman. I mean the real places like Gunan and Slushfors and other places that I also can't pronounce. This is very new research internationally and very, very interesting to our colleagues in Canada and Australia in particular, who like us have seen over the last 30 or 40 years services really contract to those what you would call regional centres like the Storumans. What does that mean for the small villages? In September, we hosted a meeting here with colleagues again from Canada and from Norway, and we formed what Andreas called the International Northern Network for Rural Medicine. And again, we've started to do some work on this. There's a stream of that looking at what does it mean to be a family doctor or a general practitioner in rural areas. What does the general mean in general practitioner? Looking at how we can engage rural communities more effectively in their own healthcare systems. So as we have this process of reducing services, we get a bigger distance between the people that we are serving and the services themselves. So how do we bridge that distance? There's a section of work on ambulance services, emergency response and so forth. And more work on the way that rural communities are changing. Some years ago, GMC was involved in an international project called Recruit and Retain. And the idea there was to figure out how to improve recruitment and retention of health professionals. That research came up with 29 solutions to these problems of recruitment and retention. I'll talk about that more in a minute. But we think we've just been funded for the second part of this project, which is to look at actually implementing these solutions. So now we think we know what works. Let's put it in practice and prove ourselves right or wrong. The second part of this new project is also very interesting for us. We're trying to apply these solutions to fields other than health. So it could be education, it could be private industry as well. We are working with colleagues in Scotland, I'll get this wrong, Scotland, Iceland, Norway and Canada as well. So that international flavour continues. Also in Canada, we have a very strong relationship with the Northern Ontario School of Medicine, and we're working with them looking at how the whole situation for rural health has changed over the last 20 or 30 years. And we'll have a conference in Australia about that next year. So that's just some of the projects that at least I know a little bit about, and you'll hear some more about some of them today. What I'd like to focus on, again, is this process of why we would collaborate and why we wouldn't collaborate. And I want to use this example of recruiting and retaining health professionals in rural areas, since it's such a hot topic. I'm doing this work with Walter and Ellen as well, so anything that you don't like about it is their part of the work. Anything you find interesting is my part of the work. I think that's fair to say. The foundation for this project is really that there have been some countries around the world who have spent the last 20 or 25 years researching and developing policy and developing approaches to recruit and retain health professionals. You might call these the high-focused countries, and they're places like Australia, Canada, South Africa, parts of the United States, parts of the UK. Sweden and Norway have done quite a bit less, although Walter and I are having discussions now about some of the stuff that has been done but kind of hidden, kind of is done below the surface. And then parts of continental Europe, and we've particularly been talking about Germany, have done almost nothing in terms of encouraging professionals to go to rural areas. What's interesting to me is that, I should show you the map. So this map is again from this Rural Health Journal, and it shows all the countries where they've written about having this problem of recruiting and retaining rural health professionals. So straight away you can see that there's an opportunity to work internationally. But despite the 25 years of work in some of these countries, the situation hasn't improved there. And this is interesting for me because some of you have heard this story, but this is my favorite story. Stone tablet from Mesopotamia, 3000 BC, the first one that's been translated. It's a whole thesis about how difficult it is to get physicians to work outside of the city walls. So that's 5,000 years ago. And at that time they said, the solution is easy. We should pay them more money. We should give them housing if they're going to work in rural areas. We should give them donkeys or goats. And we should allow them to have more wives. Most physicians were male in those days. My suggestion is that 5,000 years later, we pretty much try and propose the same sort of solutions. Although I don't know that we're offering people donkeys and goats anymore. Or more wives, but maybe we are. So the high-focus countries have tried to move on from donkeys, goats and wives. And they've done some of these sorts of things which are quite interesting. One they've done is to try and recognise that rural is its own specialty stream, and that most of this work is done on doctors, but that rural doctors should have their own professional status that comes from working in rural areas. So, for example, they set up rural doctors' associations. Rewarding people financially, we've talked about that. You can get scholarships to go to university if you agree to spend 5 years or 7 years working in rural areas. A big one is recruiting students from country towns to go and be doctors back in those country towns eventually. An even bigger one is to train medical students, nurses, whatever, in rural areas. We do a little bit of that in Sweden, but not enough. They have whole government departments set up specifically to address rural health issues. They participate in global rural networks, again about lifting the prestige of the profession. There's established research centres with the focus on rural health, including rural workforce. Up until recently there was 20 of those in Australia, although they've just had their funding changed. Using distance bridging technologies has been a big one, and adapting or changing the scope of practice for different professions. So in Canada, for example, they have what they call nurse practitioners. So these are nurses who are licensed to do quite advanced work. We haven't done much here, and it's interesting to look at what has been done elsewhere to see if we can learn from it. But there's good reasons to think we can't learn very much from these, or at least we have to be careful in what we think we can learn. The first thing is that we're not even sure that they work in the places where they've been tried for 25 years, despite those 1,000 journal articles. This is the situation in Australia. Just again, I'm using family doctors here. The red line is, the graph is about how many doctors are there for every 1,000 population. And I've split urban areas and rural areas. And you can see that urban areas have always had more, this is the national average, urban areas have always had more doctors per person than rural areas have. But what's interesting to note is over this 25-year period where we did all these things, the situation hasn't changed at all. Really interesting, in the last 5 years, Australia somehow magically found 15,000 new doctors. We have 70,000 in total, so 15,000 is a massive, you can see where they went. So we don't even know that they work in these other countries. The situation in Canada is pretty similar. When we list 29 solutions here, or we have these solutions here, we don't actually know how they work. So even when they do work, we're not sure if it's just because of one thing, or it's because the things have to be interrelated or tied together. So the research into their effectiveness has not been very good. A really important point is that what we call rural, they might not call rural in these places that we're dealing with. My work in Australia is mostly in the desert. If the colours aren't great, but you can see this is red here, and it's literally red. You don't need to go to, if you haven't been to Australia, you don't need to go to the desert because that's what it looked like, exactly that red. Out here, villages are often 200 or 300 kilometres from one another. There's no all-season, it's just dirt roads connecting them. There's no forms of transport and so on. This is a very different sort of rural to what we deal with here in Sweden. In contrast, though, down here, it's almost identical. There's a large town, 1,000, 2,000 people every 50 or 60 kilometres, 5 or 6 Swedish miles, and in between is 1 or 2 small towns. So if we're trying to learn from Australia, we have to think, well, whereabouts in Australia is somewhere that we can learn? The other thing that's really important about the types of rural is how rural is seen by society, by politics, by culture. And again, it's very different between Sweden and places like Australia or Canada. One of the things that's probably similar, though, is the view of rural as being disadvantaged and somehow needing help. And this is something that Ellen talks about. And whether there's an opportunity for us to rethink the problem, rethink the situation, not as rural being a problem, but as rural being an opportunity, perhaps. There's more differences, and I can talk about these. Health systems are very different. In Australia and Canada, you have a much stronger private health sector, so doctors are essentially self-employed, run their own clinics. You don't have, in rural hospitals, they're not driven by general practitioners. Relationships to other countries are very different. So Australia has very few international obligations. Sweden has very many in its involvement in European Union, Arctic alliances and so forth. The relationship between education institutions and health professions or health employers are very different. So in Canada, it's the health professions and the health employers who determine curriculum at universities and things like that. Oh, this is if you've been to my presentations before, you'll know that I spend 2 minutes having a go at, or having an attack on Umeå in each presentation. This is my attack for this one. Umeå University Medical School is a fantastic and internationally renowned medical school. What it is, however, is a large teaching hospital training model just transported from large cities, Stockholm, Berlin, wherever, and placed in Umeå. So what it is a wonderful facility for doing is producing doctors, nurses, and so on who know how to work in large city environments. So this is a very different approach to what they've done in Canada, for example, which is to set up a medical school which is specifically designed to produce rural doctors. The teaching is not done in large city hospitals. The teaching is done in small rural health centres and hospitals. The students are not taught in large groups of 30 or 40 people. They're taught in groups of 2 or 3 people. So more similar to what the working life is going to be like if those people stay in rural areas. But anyway, that's my go at Umeå. It's a great medical school, but it's not necessarily a rural medical school. I mentioned before about the capacity to have rural policies, or how rural is seen as in a policy sense. And an interesting one in Sweden is the history of this rural issue. So I think it was 150 years ago that the king decided there weren't enough doctors in northern Sweden. And he sent people up there, and he gave them houses, which is interesting. So did the Mesopotamians. He allowed them to have extra wives, which is interesting. So did the Mesopotamians. But what he did that was really interesting was he said you didn't have to finish your education before you could go and work in the north. So you didn't have to be as qualified as a southern or urban doctor. In my brief time in Sweden, in my opinion, this rural doctor as second class, as not quite finished education, of not quite as good as an urban doctor, kind of persists in the psyche. And it's interesting to see that there's a historical reason for that it came about in a historical way. In contrast, again, in places like Canada and the United States, the rural doctor was, from the beginning, seen as one of the most valuable contributors to opening up and colonizing the territories. So I'm suggesting that we don't just follow what other people have done. Many of the solutions resemble those donkeys and goats. I'm suggesting also that those countries who started things very early have kind of become obsessed by the solutions they think they've found, and they haven't really examined them very well. So if you look at a standard sort of innovation model, the money is made at the start by the innovators, the first people to get to market and make the money. Nobody here makes money in the middle of the innovation process. The next lot of people who make money are the ones who think that the innovation needs refreshing, needs to be renewed, or what they call regenerators, I think, here, regenerators. So GMC has an opportunity with its international research to become not early innovators, but regenerators, and make a fortune as a result. Peter can retire in wealth and happiness. In terms of the problem of attracting people to rural areas, this is kind of the solution framework that's come from the Recruit and Retain project. So you think local, okay, you need national and regional policies to support you, but people are moving to a specific place, whether it's a Storuman or a Sorsele, or I think we have people watching from Arjeplog today. A specific place. It's very different to be a doctor or a nurse in Arjeplog than to be a doctor or a nurse in Storuman, so we need to think about that. But we also need to think globally. People are moving around much more than they used to, and maybe spending the time in Storuman is part of their life ambition, not their whole life ambition. So perhaps we should be encouraging people to see our rural areas as an important place to spend some of their lives, not that we demand they spend their whole life there. Somebody comes and works here, for example, and then says they would like to go and spend 2 years working with Médecins Sans Frontières or something like that. We should say, fantastic, great idea, we'll welcome you back when you return. The other really important part of the solution package is that doctors are not important. Teachers are important, chefs are important, car mechanics are important. If your community doesn't have these sorts of people, they're not going to have doctors or nurses or psychologists either. So you need to take an integrated approach. Although mostly I just mentioned the chefs because I like to use the iconic Swedish image. Anyway, I forgot what my topic was, which was about international research and international research partnerships. So I'll just summarize that. We do a lot of them. We do them because we're looking for new perspectives, not necessarily because we think that other people are better and just need to be copied. And we do them not just to follow other people, but to lead as well. And of course, if working internationally is exciting for our students and our staff also, so we have opportunities for our own people to travel internationally and to meet new people and get involved in projects on the international stage. So working internationally is also part of our recruitment and retention solution locally. If you want to travel to any of these countries, do some interesting research, get involved in some interesting projects, please come and visit me in my little cottage.